So good afternoon to everyone. It's a great pleasure to me to have Dr. David Scollard on the program, who is the director of the National Hansen Disease Program. Dr. Scollard received his MD and PhD degrees from the University of Chicago and spent most of his career working on leprosy while teaching pathology at medical schools in Hong Kong, Hawaii, and Louisiana. His research has focused on reactions on leprosy and on the pathology and mechanisms of nerve injury in this disease, with collaboration in Thailand, Nepal, the Philippines, and Brazil. He joined the National Hansen's Disease Program in the USA in 1993, first as a research scientist, later as chief of the clinical branch, and finally as the director of this program. He was the editor of the International Journal of Leprosy, and he's currently co-editing an open access international textbook of leprosy, which is not yet complete. However, I did look it up online, and it is very impressive, and we all are extremely excited to hear about leprosy, which is kind of, I think, is a great title, not simple, and it is not eliminated. So with all that, thank you so much again for coming on the program. And please, we are grateful to have your lecture. Thank you.
Well, thank you very much. It's my pleasure to do this. It's a little different for me to lecture to the group that I cannot see. As a lecturer, I always try to get some cues from my audience, but I will do my best. I have a small picture of myself here on the title page so that you can see at least what I looked like about 3 or 4 months ago. So leprosy is not a simple disease, as I indicated, and contrary to a lot of popular concept, it's not eliminated. I have a kind of an extensive list of objectives here. It's a lot to cover, so there will be only a small amount about each item. I'm going to briefly talk some aspects of the epidemiology of this disease and clinical diagnosis. I'll talk about histopathological diagnosis and our staining and PCR techniques. Then I'll talk about nerve injury, which is really the hallmark of this disease. We'll briefly cover treatment and response to treatment, and finally reactions in leprosy. Reactions are really take up the majority of the time and energy of clinicians who are treating patients with this disease, but we usually just don't have much time to go over them, and I'll do my best in a short time. Let's see, it's not advancing. Oh, there we go. Okay, so the organism that we're talking about as the causative agent, M. leprae, was discovered in Norway in 1873. It's never been cultivated, and we now know that that is because it is missing some key enzymes in key metabolic pathways. It is a very, very slow-growing organism. The division time in the mouse footpad, which is one of the animal models, is 13 to 14 days for a single division. This means this plays out into the clinical and other aspects of this disease with a very long incubation time and so on. This organism also has a unique capability among bacteria to infect peripheral nerves, and that causes a lot of the damage in this disease. The organism prefers a cooler growth temperature of 32 or 33 degrees Celsius, and that is one of the reasons, at least, why it localizes to cooler locations on the skin. It causes a chronic infection of skin and nerves. That is what we most commonly see. It does have systemic capability of infecting bone marrow and liver as well. This is very uncommon today, and we won't really have time to discuss that, but it is important to note that there is a potential systemic component. As I mentioned, it has a very long incubation time. Depending on the study you read, I think 3 to 7 years is a pretty good range to consider as usual, as an average. It can be 10 years or longer, up to 20 years in some reports. This organism, or this infection, is extremely hard to catch, and that is because approximately 95% of the adult population in the world have native immunity to this disease and won't acquire it no matter how heavily they're exposed. This is based on some genes that have been identified and much more work to be done. But nevertheless, it means that 95% of people have native immunity to this disease. The only diagnostic test to confirm this diagnosis is the biopsy. There are no convincing blood tests and no skin tests, contrary to papers you might read. There is continuing interest in early diagnosis of leprosy, and so there is continuing interest in developing skin and blood tests, but none of them have yet achieved an appropriate level of sensitivity and specificity. So a quick look at the overview of this disease in the world. It still does exist. This is the WHO map that is current. And basically what you can see in this map is that a few areas of the world still have high numbers of cases. The greatest number of cases in the world is found in India, in the Indian subcontinent. The greatest number of new cases being seen each year now is being seen in Brazil. The Brazilian health officials have been very diligent and transparent about this, and they would tell you that they don't really understand why they're seeing the increase there. You'll also see then on this map the disease is located in a number of other places, generally in a kind of tropical distribution in the world, and it has often been classified and discussed with other tropical diseases, including today the neglected tropical diseases. But in truth, it's not a tropical disease. It is not bounded by a need for any particular vector. And historically, it has been prevalent in Europe and in very cold countries. In fact, Hansen was a Norwegian physician who described this in the late 1800s. In the United States, for those of you who are listening from a location in this country, we have two major sources of patients. One is those patients who are immigrants or migrants from endemic areas of the world, and others are so-called endemic cases, people who are U.S. born and have no travel history to other parts of the world. These patients are generally found in or have lived in the southern United States in the Gulf Coast area, and this is now almost certainly due to armadillo to human transmission. Our New England Journal paper is referenced here, and there's a more recent one last year, I believe, in emerging infectious diseases. In the lower part of this slide, you can see the sources of cases in the United States from other parts of the world. Actually, in the last year or two, the Western Pacific Islands of Micronesia and Marshall Islands, which we've lumped together, are now the number two. And then we get to Mexico, Brazil, India, Vietnam, and some other countries. But very importantly, the single country from which the United States gets the most cases is the United States. It's 21% to 24% of all the cases in the country. This is the greatest single source then, although the majority of cases do come from many other countries around the world. So I like to think of this disease as being really two conjoined diseases. The first is a chronic mycobacterial infection that elicits a uniquely broad spectrum of cellular immune responses. And the second is a peripheral neuropathy that results from the infection. And importantly, this may continue even after the infection itself is cured. The infection has generated the most research interest and the most funding. The WHO's program to eliminate leprosy as a public health problem, in fact, has been focused on eliminating infection with the disease. But the neuropathy is what causes the greatest long-term disability in this disease and often associated with a very severe stigma in several cultures. So to consider then briefly what happens when someone encounters this disease. First of all, on the bar on the left, you see I've indicated 95% of people, more or less, will not acquire the infection. So it's 1 in 20 who do. Among those susceptible people, sufficient contact is required. This generally is understood to be more than casual contact. It's not from sitting next to someone on the bus and not from shaking hands or not from having a meal with someone, but prolonged close contact, sharing the same bed or the same small home, for example. And in the first phase of this disease, we have a phase we call indeterminate. I don't think I have too many slides to talk about this. It's a very small macule that's really nonspecific and usually is found only when you are doing contact examinations of an index case in a family. The inflammatory response is very nonspecific. Indeterminate, however, does mean that we have definite evidence of leprosy, meaning we found the bacilli, but it hasn't generated enough inflammatory response to be classified according to the system that I'll show you. Again, most patients are not found at this phase. Instead, patients come into us when they have some degree of clinical lesion, and here I've shown a range of clinical findings that you can see from a small macule on the eyelid of this young lady to an extensive nodular infiltration in this young man, and a whole range of appearances in between. These are usually established lesions, and these have been there from, I think the lady on the eye was a very early case of about 1 year. The others here were there for 3 or 4 or 5 years before the patient came to the doctor. We now understand that this broad spectrum of human responses, from macules on one hand to infiltrates and nodules on the other, is related to the patient's cellular immunity. And as we go from the left-hand side of this screen, cellular immunity or delayed hypersensitivity is very high in these patients, and on the other side, at the other pole, cellular immunity is very minimal or even totally absent to this infection. As a result, we see a reverse relationship to the number of bacilli seen in the disease. On these patients at the left with high degrees of cellular immunity, bacilli are rare or difficult to find at all. On the other hand, on the right-hand side, these patients have very, very large numbers of organisms in the tissue. I do think, in fact, that there's probably no other disease that has the bacterial burden that you can see in patients with lepromatous leprosy. These are subdivided then in the so-called Ridge-Jopling scale into these 5 categories: polar tuberculoid, borderline tuberculoid, mid-borderline or BB, borderline lepromatous, and polar lepromatous. This classification scheme is based on a combination of clinical and histopathological findings, and neither one alone is usually sufficient to definitely classify the patient. You need to put clinical and histopathological findings together. So I'm starting here at the tuberculoid end of the spectrum. Imagine the lady I showed you previously with that little macule on her eyelid. You see well-formed epithelioid granulomas here. When I show this slide to the medical students, I tell them that if you were given only this slide and asked if this is leprosy or tuberculosis, the answer would be yes. We don't know until we have more information. In this case, we're looking for bacilli that can be very rare, as shown here. The organisms seen here happen to be in the deep dermis in a cutaneous nerve twig, and this is a very high magnification, but this is actually a small cutaneous nerve. Finding bacilli in a cutaneous nerve is diagnostic of this disease. It's pathognomonic. The next step down our spectrum is a case of borderline tuberculoid leprosy, seen here in a young man who did come from the Western Pacific. You can see this very sharply defined macule on his elbow. You also see a small one here on his abdomen, and a reddish, more inflamed lesion on his cheek. These were his 3 lesions, but it's important to tell his story that the lesion on his elbow was completely anesthetic. And in fact, he was brought to the attention of the doctor by a school nurse because he was entertaining the kids at recess by showing them that he could put a needle right through his skin and it didn't feel anything. And they all were crowding around him saying, "Do it again, do it again." The nurse got him to realize something was seriously wrong here and got him to the doctor. And this is borderline tuberculoid disease. When you see a patient like this, the biopsy will show well-formed granulomas, but I hope you can appreciate they're not as tightly organized as what we saw in the first slide. This is borderline tuberculoid disease. I have included here a hair follicle to remind me to mention that the inflammation in all forms of this disease does involve dermal appendages, glands, and hair follicles, and can destroy them, and that can cause loss of hair and drying of the skin that can be problematic. A higher magnification of such a case, you can see this pretty well-formed granuloma. The telltale sign here is to realize that at the margin there is a peripheral nerve. The nerve here is not invaded or involved, but the perineural localization of this granuloma could help you strongly suspect that this is Hansen's disease as opposed, for example, to tuberculosis. It does not help, however, to realize that sarcoidosis can give a very similar appearance. And the distinction between sarcoidosis and tuberculoid Hansen's disease can be virtually impossible histologically. And you must demonstrate the bacilli some way in order to know to distinguish leprosy from sarcoidosis. In borderline tuberculoid disease, bacilli are rare. They're hard to find. I might have to look at 50 or 100 oil immersion fields, and then I often find a small cluster, as you see here. There is a little group, but I couldn't find them anywhere else, actually, in this particular section. Mid-borderline disease has classical target lesions shown here. The center of these lesions would typically be hypoesthetic or anesthetic. But of interest here is that some margins are very sharply defined, as in this area. In other areas, you see this becoming swollen and infiltrated and more diffuse, so you can't clearly define the margin. This is really classical of borderline, mid-borderline disease, or as earlier classifications called it, dimorphic. And indeed, when you try to look at, it's hard to get all the appearances into one section, but I'm trying here to show you, on the one hand, we have some well-organized granulomas that you see down here in the right-hand corner with some Langhans-type giant cells. In other areas, the inflammation is more diffuse and nonspecific. This is a hard diagnosis to make by itself, and actually mid-borderline is the least common of the types. It's widely believed, although not proven, that patients from the mid-borderline can slip upward into BT or downward into BL. And that may be why we don't see them as often. When you look at the higher magnification in these patients, however, you can start to see these foamy histiocytes described originally by Virchow as looking like the head on a pint of beer, and often these are called Virchow cells. These really are not seen in the tuberculoid forms of the disease, but we start to see them as we move into the group of patients who have less immunity, and therefore we're seeing more bacilli. Here I show a few bacilli in a field. It's not really hard to find them in mid-borderline disease, although they may not be present in every field. Here we can see a cluster in an erectopili muscle, one here and another in the lower area. This is, again, mid-borderline disease, where bacilli are really not too hard to find. Borderline lepromatous disease, we start to see multiple lesions all over the body, some having a target appearance, others are little macules, and then you might see some little nodules. Biopsy was taken at the arrow here, and in these cases, we see that the granulomatous organization of the infiltrate is being lost, and they are becoming more and more disorganized. Many pathologists will call this a granuloma because it's a collection of histiocytes, but it doesn't have that well-formed epithelioid appearance. We see it at all levels of the dermis. We see here some sparing or a clear zone in the upper dermis, and this is typical of the lepromatous forms of disease. At a higher magnification, we see a disorganized infiltrate again. We see foamy histiocytes. And when we look at oil immersion, we see acid-fast bacilli in appreciable numbers in almost every field. This is, again, borderline lepromatous disease. And finally, the polar lepromatous form of the disease. We see all types in all age groups, and so I have here another child to illustrate. This was a hard diagnosis to make, and compliments to everybody involved, including the grandparents who were taking care of this child, who just realized this wasn't right. This little boy had these little pimples like this, 10 years old. He had these lesions on his legs, and they were on biopsy polar lepromatous disease, but still in a fairly early state. In contrast, you see these two photos at the bottom, the classical leonine facies of this disease. Fortunately, we don't see this very often anymore, but you see the eyebrows have been lost, again, because of the infiltrates of hair follicles. You see the thickening of the ears, and you can see that also in this man with this diffuse nodular infiltrate in his face. These patients, lepromatous patients, if you take a biopsy from these lesions, you might see something like this, diffuse clusters of foamy histiocytes, a disorganized infiltrate. It may involve most of the dermis, as shown here. And the inexperienced pathologist often thinks that this is some kind of histiocytosis. If you do a phyte stain, however, you see enormous numbers of organisms in these patients. This is a phyte stain, and so everything that is red is acid-fast bacilli. That's not collagen. And this is a low magnification, as you can appreciate. And high magnification, on the left here, you see very large numbers of bacilli in every field. These clusters, we would call them microcolonies today, but originally they were described by the early pathologists as globi. On the right-hand side, again, you see the foamy histiocytes that you would see in the H&E section of this disease, and the phyte stain will reveal the organisms. So here is that spectrum in a nutshell. We're moving from the highly organized granulomatous infiltrates of polar tuberculoid disease through the borderline portion of the spectrum where it's becoming increasingly disorganized, and finally to polar lepromatous disease where the infiltrate is truly disorganized altogether. These patients have little or no specific immunity to M. leprae, but it's important to note that these lepromatous patients with large bacterial load and minimal infection to M. leprae are immunologically normal in other respects. So this is not AIDS. These patients simply have a difficulty in dealing with this particular organism. This is the spectrum again. I left out BB, but you see the tuberculoid forms on the left and the lepromatous forms on the right with their high bacterial load. I want to take a little digression here for the pathologists who are listening in, because it's very important to do a phyte stain. M. leprae is weakly acid fast, and depending on your lab and how thorough your decolorization is, you can be fooled. The slide on the left was sent to us in consultation from a very good university laboratory in the United States. They know what they're doing. They were very suspicious that this was leprosy, but their acid-fast stain was negative. We took the sections they sent us from the same block, and you can see on the right how heavily these were infected by M. leprae. So a phyte stain, if you don't see bacilli with a typical Ziehl-Neelsen stain, you haven't ruled it out. A brief note also about PCR for M. leprae. We use a real-time qPCR for what's called an RLEP sequence in the 16S heat shock protein portion of the DNA of this organism. This is where a lot of mycobacteria are actually sequenced to identify specific areas. We can extract the DNA of M. leprae from formalin-fixed paraffin-embedded tissues. 70% ethanol is optimal, however, if you are thinking about PCR. Of course, that's not really optimal for histology. It's important to note, and this I can't emphasize enough, PCR is an excellent identification tool, and that's important to us because we cannot culture the organism. However, contrary to the expectations of almost every infectious disease specialist and most pathologists I deal with, they don't expect this to be a poor detection tool, but it really is. In a recent review of a number of our cases, you can see here PCR was positive in only 34 of 296 cases. That is when AFB were not seen. So we're talking about a 10 to 11% take if we don't see acid-fast bacilli. That means that most of the time, if we don't see bacilli in a good phyte stain, in a good section, PCR is going to be negative. For this reason, it's not good to wait for the PCR results. If you have good clinical evidence of this disease, if you see some bacilli and there's a likelihood of this disease, start treating. If it turns out that it is an atypical Mycobacterium on later studies, you will have already used some effective drugs and you can modify the treatment. When bacilli are rare, then, the amount of amplifiable DNA is just below the detection limit. This is a look at the spectrum as we see it, focusing on nerves. And I want to do this because I think it's so important. If you send a biopsy for asking the pathologist to rule out leprosy, if they don't comment on the nerves, send it back and ask them to look and comment. The biopsy, a report where leprosy is being considered should comment on nerves. And I'm showing you here then what we can see across the spectrum. In tuberculoid cases, this is the granuloma. This is an S100 stain, and that's all a nerve we could actually demonstrate here, just the last remnant of a nerve that's been eaten by granuloma, and a higher magnification in a fight stain shows us bacilli in the nerve. In the borderline tuberculoid disease, these are, again, skin biopsies. This is the kind of thing you would see in a skin biopsy that would tip you to think this might be Hansen's disease. This is a granulomatous infiltrate that's certainly involving cutaneous nerves. And again, you do the fight stain, and if you're lucky, you can find bacilli within a cutaneous nerve twig. Of course, that doesn't always happen in the section you have. In the borderline lepromatous form of disease, I want you to notice how similar borderline lepromatous and borderline tuberculoid can look. Clinically, they can look quite similar as well, and the biopsy is really the way you can distinguish them clearly. So you have nerve twigs being involved. Here, however, when you do the fight stain, you see lots of bacilli, and some of them are in cutaneous nerves. And finally, on the right-hand side, a lepromatous nerve twig that's been captured here. There's intraneural foamy cells as well as perineural foamy cells. Fight stains reveal these enormous numbers of bacilli. You see the nerve twig here going down the center with bacilli inside it and around it. What's remarkable is there's probably still some nerve function in this nerve, even though it's so heavily infected. In the end, of course, if not treated, these will all develop nerve function impairment and probably anesthesia. The majority of disabilities in leprosy result from nerve damage, and when they involve the trigeminal and facial nerves, you can get leg ophthalmos and corneal anesthesia. That, in very tragic cases, if not found earlier, leads to a situation like this. This patient had to have this eye enucleated. He had minimal sensation of light in the other eye, which we were able to preserve. This is due to anesthesia of the cornea. And then with leg ophthalmos, you can't close the eye, you get corneal scarring. This is an example of what happens when you have profound anesthesia of the hands or fingers, which means total lack of sensitivity to any kind of pain. This patient jammed his finger in a car door, didn't realize what he'd done until a few days later when he looked at his hand and saw the inflammation. At the most extreme, this can result in reabsorption of digits, so that you see here a man with fingernails on every finger. These fingers haven't dropped off, and they haven't been amputated. They have been extensively absorbed. Absorption can occur. Of course, a lot of times patients have loss of digits that results from partial amputations, also when they've developed osteomyelitis and so on. And when this happens in the feet, we have people who are susceptible to injury, to pressure, because they don't feel the stone in their shoe or the pressure from the callus on their foot. And these patients are going to require lifelong care for these disabilities. So this is a slide I use from our own program, but really this is the mission of leprosy treatment around the world, is to try to prevent or arrest a trajectory of nerve injury in this disease. And we do this by treating the infection. The chemotherapy we use, multiple drug treatment, is very effective, although it takes some time, as I'll show in a moment. And so what we're trying to do is to arrest this trajectory. If we can find patients early and get them treated early, we'll have minimal or no nerve damage. There is almost always some nerve involvement at the time of diagnosis, as evidenced by the fact that there is some degree of cutaneous anesthesia or hyposthesia. But if not caught early enough, it can go on to produce nerve damage, ultimately nerve disability, and visible deformity. This is not only important to the patient in terms of quality of life, but it's also important to the medical care system of any country treating these patients, whether you're in the United States, which has lots of resources, or countries which have minimal resources. The cost of treating an early case is very low, relatively low. The cost when patients have developed lifelong disabilities and deformities, like I showed you in the previous slide, this becomes a very high cost because these patients are going to require some degree of care for life. The treatment that we use, and again, I'm sorry, I will mention in a moment the WHO recommendations, But the standard treatment regimen we use in the United States is for tuberculoid, or what WHO calls paucibacillary disease. We use two drugs, dapsone and rifampin. We recommend giving both drugs daily, and we recommend doing this for 1 year. In lepromatous patients, or WHO categorizes them as multibacillary patients, we add a third drug, which is clofazimine. This is a dye which is a weakly bactericidal, but in combination with these other drugs is very potent. It's especially effective because it is concentrated as a foreign dye within the macrophages that hold the bacilli. We use these three drugs, again, giving them every day for 2 years. Now, we have ample evidence that treating with these treatment regimens do kill all the bacilli. I don't have time to go into all that evidence. What we don't have is what you have in tuberculosis, where you can culture sputum and show that it's negative for culture. Since you can't culture this organism, we can't do that. Some tests are now in development that may enable us to get direct evidence about viability from patient biopsies, but those won't be ready probably for 2 or 3 years for field use. So this is what we use in the United States. Globally, the WHO uses the same drugs. We all recommend the same drugs. They put them in blister packs, and in those blister packs, rifampin is given only once a month, 1 dose. And that goes back to the early 1980s when MDT was put together, and rifampin was too costly to provide every day all over the world, and so it was given once a month. The United States went to giving it every day anyway, and many other developed countries do as well. The WHO initially recommended 1 year and 2 years, and since they have revised that to recommend only 6 months for the paucibacillary patients and 12 months for the multibacillary patients. This remains a controversial move, and in many developing countries and places I've visited with doctors, on at least selected cases, they extend the treatment to 1 year or 2 years, thinking that the shorter treatments are just not enough. Again, that needs a whole lecture by itself. It's somewhat controversial, but that is what is done in most of the world today. Globally, the World Health Organization distributes these medicines at no cost to programs, and they should be available in every district to every patient at no charge. In the United States, these medicines are provided by the National Hansen's disease programs, again, at no cost to patients. Looking at the effective treatment. I'm going to show you a series of slides. This is the way a patient presented to us. He'd had the disease probably for a few years already, and this was his baseline photograph. Over the years, then, he got our treatment with all these three drugs daily. You can see after 1 year, a good degree of resolution, but still lesions are definitely visible. Even at 2 years, some lesions are still visible, but he certainly has improved. It's important just to point out that there is resolution, but it's slow. You may not see anything in the first couple of months. You might not even see anything impressive in the first 6 months. And this can be very discouraging to the patient and the doctor. You just need to know to persevere. So this is the patient at 2 years. We stopped treatment here because we were convinced that all the bacilli are dead. But you can see then in subsequent years, 2012 and 13, how he continued to clear. It may take several years to get complete clearing of all the lesions. Now I want to show you what happens when we look at serial biopsies. These are from a different patient, but his serial biopsies from one lepromatous patient. This was his baseline biopsy. We see globi, we see lots of bacilli everywhere, a classical lepromatous case. He was given 3 drugs for daily, and he was a compliant patient. At the 1 year visit, then, we saw this. And here I have to pause. This is where the WHO tells you to stop treatment. And this is where a lot of doctors don't want to stop treatment. When I show this slide in lectures, I ask for a show of hands who wants to stop here, and nobody wants to stop here. We still concerned that some of these bacilli are alive, but I do want to point out that they've become disaggregated and they show a lot of beading and degenerative changes. When I see this change, I can tell, especially if I had an initial biopsy for comparison, that the drugs are on board and the bacilli are actually responding to them, but we're still not out of the woods. This is then the biopsy we took in the same patient at 2 years. Here, we did stop the treatment. But you will note we still see bacilli present. This is where the infectious disease specialist, who's conditioned to think that when you've treated the infection, the bacilli would totally be gone, has to understand that in this disease, dead bacterial bodies persist in tissues, sometimes for several years, as I'm going to show you. We stopped treatment here, convinced that we had killed them all. And then at 3 years, we still see some bacilli here. You can see a cluster as well as individual bacilli in several areas. At 4 years, I'm circling them now so I can find them easily. We still saw bacilli. At 5 years, I could still find bacilli. And I don't have that slide, but even at 6 years was the last time I could find bacilli in this patient. There are several messages here. First, dead bacilli persist for a long time. Second, just seeing bacilli doesn't mean that this is active disease. And so I'm going to go back a couple. I very often get a biopsy in consultation from a pathologist who sees something like this and says lepromatous leprosy, active disease, because he sees bacilli. And the point is, you can't know that it's active unless you had the original biopsy or an earlier biopsy for comparison. Because unlike most diseases, you can still see dead bacilli even when the infection has, the bacilli have been killed. Okay, so the clinical, before I go on, I'll take a little pause here. I'm using my time, but I've covered the basics of Hansen's disease, and I wonder if there are any questions or comments at this point.
I'm checking on the chat window. No,
Okay.
I would keep it going. I think that there will be lots of questions at the end. I'm sure
Okay.
about it.
Very good. I'll just continue.
Thank
So
you.
to kind of summarize what I've said here, clinically, patients present with a chronic rash or skin lesion of some time, but often they don't feel sick. This is quite striking. Especially lepromatous patients can have enormous numbers of bacilli. They don't even have a fever. They often, or frequently at least, visit the clinic for some other problem. They might have sometimes the dentist's office where they have a toothache or something, and in taking the blood pressure in the dentist's office, someone will see a rash. Or they even accompany a family member for another reason. These patients then with a basic leprosy are often not sick and they're not seeing the doctor unless the disease causes them some problem, either cosmetic or functional with their hands or feet. However, about 40% of patients will become sick, and these patients have leprosy reactions. This is less common. Again, it's 30 to 40% of patients. They come sometimes to a clinic and sometimes to the emergency room, and I'll tell you that no emergency room physician is expecting to see leprosy and make that diagnosis. They can look septic, as I'll show you in a moment. Distinguishing reactions and relapse. This is a question I often get. Reactions affect 30 to 40% of patients. Relapse occurs in less than 2% of patients globally. Just on this alone, you would realize that usually when patients are developing new lesions, it's a reaction, it's not a relapse. New lesions occurring during and after treatment then are almost always reactions. Reactions are natural immunological events that occur in the course of this disease in some patients. They are not drug reactions. Looking at the spectrum again, from tuberculoid to lepromatous, we have two main types of reaction. Type 1, sometimes called reversal reaction, occurs in patients in the borderline portion of this disease, any of these borderline areas. Type 2 reactions, or ENL, erythema nodosum leprosum, occur in people at the lepromatous end of the spectrum, and the further you go toward the lepromatous end, the higher the risk is that the patient might develop such a reaction. I want to show you, rather than just describing these reactions, the patient, this was supposed to be animated, so it would be a surprise for you. But on the left, you see this gentleman who came in, very pleasant man, had borderline lepromatous disease, We told him we were going to treat his infection, we could cure him, but we also said things could get worse before they can get better. So if anything happens, call us. He came back about 2 months later, and you see him on the right, and he said, "Doctor, your medicine made me sick." And we said, "No, sir, this is a reaction. We told you this could happen. The medicine is doing the work. It's killing the bacilli, but you, unfortunately, were susceptible for a reaction." This is a type 1 reversal reaction occurring in the borderline types of Hansen's disease. This is another example. This is a young child, young teenager, who presented with these lesions, very red and angry looking. This is a borderline lepromatous disease also, but he presented with a reversal reaction at the time of diagnosis. This is a reversal reaction in a classical old slide from the Cargill catalog. It can often cause acroledema. These patients will say they can't get on, they can't put their shoes on, and you can see we've had some tissue breakdown at the ankle. What you see is an angry red lesion surrounding the knee that was a macule that was visible before and now has become very red. Unfortunately, we don't necessarily see diagnostic signs of this terrible reaction histologically, and I showed the two slides here from a patient. A was the patient before a reversal reaction, and B was in the midst of this reaction. I've shown this slide at conferences and to experienced pathologists. If they don't know which is which, you can't tell them apart. Sometimes these patients with type 1 reaction will have an increased number of giant cells or some other evidence, especially if you have a baseline biopsy to compare, where you could say there is a consistent with an increased inflammatory response. But the pathology doesn't show not anything like the drama that you see clinically. What's happening here, and I'm going to touch on this briefly, mainly what we're seeing is upgrading. Patients have a spontaneous enhancement of cellular immunity, so they'll go from BL to BB, BT to TT, or BB to BT, or BT going toward TT, an upgrading of the reaction. Again, this is enhanced cellular immunity. We see in the skin, we can see increases in CD4 T cells, increases in CD1 positive dendritic cells, Th1 cytokines. Interestingly, we observed an increase in the chemokine CXCL10, which appears to be much higher in patients with type 1 reactions and may evolve into a diagnostic test, but we don't know that for sure yet. What initiates them, we don't know. We can talk about this in another lecture, but we simply don't know. A common denominator seems to be some kind of stress. It can be psychosocial stress, a divorce. It can be physical stress, surgery, losing your job, a lot of things. Sometimes, though, we can't identify a stress, so we just really don't know. The other reaction we see in this disease is called erythema nodosum leprosum. You see several different versions of it here. This has an abrupt onset, as erythema nodosum does in other diseases as well. And so this patient might tell you that I was well 2 days ago, and now I've got these bumps all over my body. They're red and tender, not necessarily located where previous lesions were. Histologically, in this case, we can see foci of polymorph infiltration superimposed upon this chronic process. You see here the foamy histiocytes of lepromatous or borderline lepromatous disease, and then you see multiple infiltrates of polys. Polys are so rare in this disease that if I see one, I comment. That's not enough to make a diagnosis of VNL, certainly, but I comment. Even if I see one polymorph, it's so extraordinary that you can have such an extensive chronic inflammation without any polys. So even one prompts me to comment that this patient might develop ENL, although we can't diagnose it histologically on one. We can in a setting like this, where you see a real focal infiltrative polymorphs. Now, I want to emphasize a little bit again about these reactions. Data I'm showing you here isn't published yet, but it's from a large multi-center study we did in Nepal, the Philippines, and Brazil, looking at almost 2,000 patients. About 15% had a reaction when they first came to the doctor. That's what brought them in. And so that's our baseline. Then we looked at those patients who didn't have reaction and followed them over the course of multi-drug treatment. The WHO protocol was being used, and so these patients were being treated for 1 year. You can see that over the 1 year, some of the tuberculoid or post-bacillary patients developed type 1 reactions, but especially note that in the lepromatous group, we had a continuing progression of development of reactions throughout the course of 1 year follow-up, and I believe but don't have the data to show that this continues into the second year. This is why, so there's not one trigger point, and treatment doesn't cause the reaction. Whether it might precipitate reactions in some people, I really can't say, but it doesn't cause the reactions. And you see them throughout the course of treatment. And importantly, once you stop treatment, you will still see some patients coming with reactions. So how do we treat them? This also is a lecture in itself, but putting it simply, we use corticosteroids for both types of reactions, sometimes high doses. ENL can, in fact, we've seen more than a few cases presenting to the emergency room and getting a very expensive workup for sepsis before somebody tumbled to the possibility of Hansen's disease being the diagnosis. Corticosteroids are used in these patients sometimes starting at 40 to 60 or even more milligrams a day, and then trying to taper rapidly off the high doses. But some of these patients are going to need corticosteroids for prolonged periods of time, months, or even extending into a year or two. That, of course, has all of its own difficulties with side effects. With erythema nodosum leprosum, one can increase the dose of clofazimine. This will increase the pigmentation of patients, and that's sometimes something they don't want. Clofazimine is anti-inflammatory, but not nearly as potent as corticosteroids. It does reduce the frequency and intensity of reactions as best we can tell. The other interesting point here is that thalidomide is an extraordinarily effective drug for erythema nodosum leprosum. This was discovered just before the birth defect side effects were discovered with thalidomide, and it's the reason that thalidomide remained in the formulary anywhere in the world was because of its effect in treating erythema nodosum leprosum. In the last 10 years or so, of course, there's been a renewed interest in thalidomide for other reasons. It is medically the drug of choice, but it isn't usually the first drug used because of all the concerns about birth defects and the very rigid controls that have to be used when it's being used. So the duration of treatment is empirical. You go as long as needed, and if you're treating a patient with one of these reactions, if you're not already experienced yourself, you should consult someone who can help you walk yourself and your patient through it. It's important to understand and to tell the patients reactions do ultimately go away. But it can be a period of a few years where patients are quite miserable with continuing or recurrent reactions before the whole problem is resolved. We think that this is due to the fact that these dead bacilli and even the antigens we can't see might trigger these reactions or be the focus of them, but we still don't understand the mechanisms well enough to describe this very well. So in summary, leprosy is not eliminated. It is rare in the United States and in many countries, but it is not eliminated worldwide for sure. There is a wide range of histological appearances with well-organized granulomas at one extreme and totally disorganized infiltrates with abundant bacilli at the other extreme. PCR is good for identification, not really good for detection. Nerve injury is the hallmark of this disease, and it's the dangerous element that causes most of the problems in the long term. The infection is curable. That's so important to emphasize. The infection itself is curable, and as soon as patients start on treatment, within a day or two, they become non-infectious to other people. So from an infectious disease point, this disease is very manageable. It's the disability issues that are the problem in the long term. Finally, reactions are fairly common in this disease, involving 30 to 40% of patients. Relapse is rare, so the development of new lesions during or after treatment is usually due to a reaction. I always like to end with this slide as well. From the Indian Leprosy Congress several years ago, they had these nice t-shirts. I couldn't get one, but I got some pictures. On one side it said "Got Leprosy," and the other side said "How to Cure Leprosy. We use MDT. Free, available at your local health center." So that is what I have to offer. This is my contact information, my email address. I also would take this opportunity to mention again the textbook that Laszlo mentioned at the beginning. The International Textbook of Leprosy is in progress. We have about half the chapters, or a little more than half of them, are up. We hope to have it all online by the end of this year. The authors of every chapter are highly experienced, and in most cases the world authority on the area they're writing about. And so this is in time going to be, I hope, a very valuable resource, and I encourage you to check it out now or bookmark it for a later time when you have questions and you want to look for textbook answers. I will conclude there, and thank you for your attention, and I'm open for any questions.
Thank you very much, Dr. Scollard. We learned a great deal, and actually I was kind of thinking that I can listen to this lecture more and more, or just kind of open up new areas regarding treatment or pathology. There are a couple of questions. One of them is, what would be the management of close contact persons for a, I don't know, maybe a tuberculoid or a
Okay, that's a very, very good question. So the traditional standard advice, we don't use chemotherapy, we do contact exams. We don't use chemoprophylaxis. We do contact exams, yeah, and the experience around the world, and sometimes in published papers, has been that the highest yield in doing those contact exams is the first exam of the members of the family or close contacts. What we tell in the United States, we try to examine the family, and then if we don't find anything at all, we tell them there's nothing, and there probably won't be anything, but if anything should arise, go to your doctor. And that's really been the standard advice around the world. Now, there are 2 or 3 large chemoprophylaxis trials in progress that have used single-dose rifampin. They have been able to show an effect of rifampin in reducing the number of cases, but after 2 years, there's no difference from the control group. So it's kind of a proof of principle study, but it seems that at least in high endemic areas, single dose of rifampin is not enough. There are some other studies now being proposed to look at other forms of chemoprophylaxis, but so far these are all in research mode. So the advice on a practical basis in everywhere and around the world is do contacts exams, treat anybody in the family who might have a lesion, and then just ask them to return if they have a problem.
Thank you. The other question is, if you have a patient with suspected dead bacilli on pathology, but don't have an old biopsy for comparison or detailed history of prior therapy, would you treat the patient again? And if so, for how long?
Yes. Again, looking at the bacilli, we can't tell if they're dead or alive, and that's the problem.
Yeah.
Sometimes we have a history of some remote history of treatment. It's even 2 or 3 years ago or 5 years ago. The details are sketchy. If we see appreciable numbers of bacilli, we often will advise, depending on the clinical syndrome as well, does the patient have active symptoms? Sometimes in those cases we will recommend a repeat course of treatment. And if we're going to repeat, we go the full course, either 1 year or 2 years, depending on what type of disease the patient has. This is a difficult question. There's no simple answer. But if in doubt, and if the patient, if there is evidence that makes anyone think this might be active, we would consider retreating. The other thing you can consider is, if you're going to get good follow-up with this patient, if they're fairly compliant and so on, is just to follow them. If they can come to the doctor a couple times a year, If their lesions aren't getting better, aren't getting worse, but do indeed seem to be getting better or no change, probably everything is okay. Because we don't have a specific test to tell us about viability, this is a difficult question. And so you really probably want to consult a specialist in your area to decide what to do in that case.
Thank you very much. Connected to this question, I have also a question that, have you tried to culture organisms from a 1 year out biopsy? It was very impressive. For me, it was a totally new thing to learn that this is actually happening. But as you showed, they had this beaded appearance. Maybe it is just the skeleton or the outside membranes of these bacilli. So would you be able to culture these, and that would be like the proof of the principle, whether they are still infectious and able to reproduce or not?
Well, yes. So since we can't culture them in vitro the way we would with staph or strep or TB, the culture is the mouse footpad. This requires enough bacilli to inoculate in the first place, and then it takes 6 to 9 months when you harvest the mice, and another couple of months to treat it. So your culture takes a year to do or more to get an answer. Right. But in the early days of multi-drug therapy and so on, these things were done, and so there are old papers, and the answer is that they would take cases that had been treated for a year or longer, and where there were abundant bacilli that you could still see in the lepromatous patient, and they do the mouse footpad inoculations, and nothing would grow. In most cases, sometimes something would grow, and that was the basis for saying, well, let's treat them for 2 years. And after 2 years, they never got growth.
I see.
You don't try to do these studies on any routine basis because the mouse footpad technique is so clumsy. What I referred to earlier about techniques for viability that are actually coming out of our laboratory research group here in the National Hansen's disease programs is to take extract bacilli from a biopsy and look at a ratio of RNA to DNA. DNA, when you have enough controls and the right techniques, DNA can give you a surrogate number for a bacterial count, so sort of a denominator. And RNA, and they've looked at different RNAs to see which ones are best. Certain ones, of course, can give you an indication at least that this bug was probably viable. So looking at a ratio of RNA to DNA can be used as a viability index. This is actually being field tested now in multiple centers in a study. Based on mouse footpad studies, it appears to work very well. And we can tell you that, after 1 week or 2 weeks or 10 weeks or whatever, the bacilli are dead. But it isn't ready yet for use in a routine setting, and so that's probably going to take a few years.
That's a great idea. Thank you very much. And this is more of a histopathological question. That when you are showing the nerve damage between the tuberculoid and the lepromatous cases, in both cases you have bacilli there. However, the reaction in the tuberculoid form and the effect on the nerves is way more, way stronger, way more significant in the tuberculoid form. Do you see clinical differences in pain sensation or sensitivity between lepromatous cases and the tuberculoid? Because the histology, to me at least, is suggestive of that. Although the tuberculoid is like there is more immune reaction, but it is like with hepatitis, that if someone has hepatitis B infection, then actually the hepatic damage is due to the immune reaction and not necessarily due to the viruses. So is it the kind of similar here between tuberculoid and lepromatous?
Well, there is a similarity, and your illustration at the end is good. What happens in tuberculoid disease, as you've implied, is that the granuloma is causing the damage. The number of bacilli is so small that alone, if they were growing in the nerve, it probably wouldn't do much. The granulomatous immune response that we see as a granuloma is doing the damage. Now, there's a whole chapter in our book about mechanisms of nerve injury, and there's a whole chapter, of course, because if we knew the answers, it'd be a paragraph. So how that injury is happening is still very much under study. But at the lepromatous end of the disease, or in the borderline, where you have more bacilli and they're growing inside the nerve, the lack of the immune response means that the development of neurologic symptoms is slower. So in a simple answer to your question is that the tuberculoid patients generally will present symptoms that the patient notices earlier, whereas lepromatous patients may go for a long time not really noticing the mild anesthesia or something. But all types of disease are having injury. And the final common pathway for all of them will be anesthesia. No matter if you start lepromatous or you start tuberculoid, if the disease is allowed to progress in the natural course, some patients in all types are going to develop severe anesthesia and motor loss and paralysis of fingers or toes and so on. The route they get there is different, but the final common pathway is the same.
I see. So these self-mutilation that you showed pictures on, those are more common in case of the lepromatous or the tuberculoid?
Well, they can be in both types, and this is why sometimes people have asked me which is the worst form of leprosy. And if you're an infectious disease consultant, the one with most bacilli is worse because you're thinking about infection. But if you're thinking about nerve injury, both types can suffer nerve function impairment. Again, the tuberculoid classically develop it more rapidly, but in the lepromatous types, it can also occur over time. And so in the end, when we see lepromatous patients who have profound anesthesia and don't feel the stone in their shoe, for example, just like we have tuberculoid patients who do that. So that the degree of anesthesia alone doesn't distinguish, or even paralysis and deformity, doesn't distinguish the type of disease. You can see all of these in all types.
Thank you very much. And a very last question. You mentioned that these patients who has, for example, severe lepra disease, otherwise could have a good general health. They are not susceptible for other infections like, an HIV patient. So is there a study that is looking for, I'm talking about a genetic study, that would look into that common denominator, at what kind of cytokine or interleukin maybe these patients are lacking, or interleukin receptors they are lacking, that make them susceptible for either type of this disease?
Well, that's an excellent question too, and of course takes another hour of lecture or more. The simple answer is that we now understand the genetic response, the human genetic response to this organism is really controlled at two levels. First is innate immunity. You get it or you don't. And again, about 5% of people appear to be susceptible. The first really good gene association with this, it was the first application of I can't say the word I want, but the gene anyway is a regulatory gene in the Parkin complex. This was published by the group in Montreal, Erwin Scher's group, and the first author was Marcel Mura, and in Nature about 10 years ago. We now have more susceptibility genes that have been described. It was positional cloning is what they did in that first paper. So that's the innate immunity level. If you are susceptible, then a whole bunch of additional genes come into play to determine whether you're likely to be on the lepromatous side or the tuberculoid side. And these genes, not surprisingly, are associated with a whole range of T cell molecules, cytokines, and so on. No one yet can give us a simple genetic profile that can tell us who is going to go where. So this hasn't been unraveled enough yet to be able to give a simple explanation that links one gene, let's say a T cell gene, with a certain cytokine with a certain type of disease. That's still work that's in progress. But there are two types of genes then, the overall susceptibility genes and then the T cell genes that modulate the type of response if you are susceptible. And this genetic work continues in several laboratories around the world. The molecular geneticists and molecular immunologists find this to be an exceedingly intriguing model because nature has done the experiment and we simply need to understand how it plays out.
I see. Well, Dr. Scollard, thank you so much again, for this excellent lecture. We all greatly enjoyed it, and maybe sometimes we could have you back for a more specific topic around leprosy. I mean, I personally would be very much interested, to hear about it. We definitely learned a great deal, and I can only say that we really appreciate your time, and thank you again a lot.
Well, thank you. It's been my pleasure.
Okay, so for everyone, we will meet next week, and or maybe not next week, but the week after. And until then, have a good night, and thank you for joining tonight. Okay, bye bye.